I have heard the term diabetes, and that's for that reason. And the reason these are important trends because we need to prevent them because these are all high risk for developing cardiovascular disease some point later on in the life course. And then of course, recently we had a CDC grant that's been focused on pre-diabetes, and this is sort of that trying to, and you'll find a similar pattern in what we talk about in public health. We're trying to go upstream and more upstream, and part of that is we're trying to prevent rather than have to deal with complications and actual expensive disease management down the line. And again, another map here, we kind of, we now have been moving towards trying to hotspot areas where we could then do more appropriate policy and program planning. And this is to give you an example. If you take a service planning area 4, and if you look at Asian and Pacific Islander as a group, this is just an example. We do this with other groups as well. You could kind of see some of the variety and differences. Now what's important about this is this allows us to kind of say, well, where are the hot spots and where should we more adequately, or should we actually invest some of our energy into. Hypertension, of course I have mentioned blood pressure control is very important. This data actually comes from, we had done a study with the National Center for Health Statistics. This one actually uses NHANES data, and it's just comparing how LA County is doing in terms of hypertension, in terms of awareness, treatment, and control with the United States. And as you can see, we're actually not doing too poorly. But one thing I consistently pointed out to my colleagues when they're talking about program planning and policy planning, if you look at that last one, the controlled blood pressure, even though if you look at the two from 1999 to sort of 2014, even though we have improved, the fact of the matter is over 50% still is not controlled. So like I think a lot of the work that RightCare initiative and all of you guys are doing are extremely important because we really do need to get that under control. And so even though this represents an improvement, it tells public health that we have not we have not done our due diligence to making sure that blood pressure as a risk factor is reduced. And what does this all kind of mean? We also know that, as I mentioned, social condition and other factors could contribute to the CVD mortality, morbidity. If you look at life expectancy in LA County, this is one of the slides that I actually put in every slide deck, which is to say, it's quite different. It does, even in a place like LA County, where you live actually does impact how long you live. And as you could, if you look at this, again, not too surprisingly, in impoverished areas where you don't have the resources and adequate access to care. We also know that things demographically is changing, older adult population, it's rising. I think there's an estimate by 2030, I think those over 65, the baby boomer generation finally is going to arrive, and it's going to be about more than 2 million people. And interestingly, it also means that health agency like local health department, like public health, needs to rethink its priority. We're still very youth focused, and by the same amount of time, the younger population actually going to decrease. I think they're going to go down from 1.7 million to about 1.2 million people. So, some other thing I mentioned, we do a lot of policy development. One area we do a lot of work with is actually tobacco use and environmental exposure. Obviously, when you think about tobacco, cigarette smoking, or smoking prevalence, you think about things like lung cancer and asthma and a lot of respiratory. But one of the key risk factor actually for CVD is smoking. And so we've tried to hit very hard on trying to reduce cigarette smoking. So to give you an example, we've actually, public health is proud of the fact that we've been driving some of this prevalence down. Back in 1997, smoking was at 18%. We're currently, even though this stops at 2011, we're still around 12, 13% currently. The interesting thing, though, our work is not done, because if you start breaking it down by subgroups, we can see there's still a lot of disparities, right? African American still smoking prevalence is higher, and as you know, that group CVD risk are also higher. So this is actually a MMWR report that actually recently came out talking about just prevalence of tobacco product use among Americans. They actually did it by state too in California. I wanted to show this because one of the issues around tobacco use currently is, just as we think we're making headways with regular tobacco, electronic cigarettes and e-devices have now come to the forefront. And I think last week, I believe, the FDA actually declared this to be an emergency or an epidemic, especially among youth. And again, if you look at, this actually is the California Health Interview survey data. Again, if you break it down by race, ethnicity, and gender, you can see that some groups are actually not decreasing in the use of cigarettes. In this case, the African American population has actually, at least in LA County, has gone up to about 22%. Smoking cessation counseling, we know that in the healthcare arena, we've been working on health policies around this. This is data from our health agency, which includes the Department of Public Health Clinics, Department of Health Services, Department of Mental Health. This idea of just screening and even offering cessation counseling and services, we're not quite there yet. As you can see, health services seems to be doing okay, but a majority of those who are smoking are those with mental health disorder, and we certainly could improve on that. And then, of course, our own public health department, I guess, I probably should not have shown that one. but we definitely need to get a lot of our health center clinic to actually screen and work on this. And then in the background, of course, air pollution continues to be a problem. So these are kind of contributes to some of the issues. So in terms of what are we doing with public health, and again, as I mentioned, what we're trying to do is try to make the environment services of high standard, but also making it so that it's easier for people to live healthier lives and actually prevent some of these conditions. So there are some state and local initiatives that's been ongoing. We've certainly been a leader in tobacco control. We continue to pass a lot of smoke-free workplace laws, smoke-free restaurant laws, smoke-free bar laws. We do a lot of hard-hitting counter-advertising campaigns, which you may have seen. I know in LA County, if you look at a snapshot, we've certainly passed 142 policies in more than the last decade. We're on the verge, actually, and it should come out in the next couple of weeks. We're on the verge of actually significantly improving our tobacco retail licensing laws so that we actually could even get menthol banned from some of the tobacco stores. And then, of course, we've been fortunate because in 2016 the state did pass Proposition 56, so we actually have influx of funding to actually do a little bit more proactive both policy development around local tobacco control, but also cessation services, and perhaps even starting to work with continue to work with collaboratives and maybe expand our work with collaboratives like RightCare.Berkeley.edu to kind of do some of this work. These are some of the priority areas, some of the policy we are starting to work on and continue to work on. is trying to work with housing authorities to actually reduce secondhand smoke exposure. We could do that through multi-unit housing smoke-free policies. And then, of course, smoking cessation, we've been promoting and will continue to promote 1-800-NO-BUTS. This is like the anti-smoking line. In terms of the clinical arena, one of the exciting things we're hoping to do is we're trying to embed, at least for the health agency, what we call a behavior design team. The idea is that we've, over the last several years, have noticed that it's not so much that provider do not understand smoking, screening and smoking cessation services or even counseling. Oftentimes it's a workflow issue, and I think what we're trying to do is if we could put together a team that is almost like a technical expert that could actually work with each of the clinic on improving workflow so that they could actually screen and treat people with smoking addiction, but in a way that is tailored to each of the clinics. So that it's not one size fit all, but some of the fixes could be very simple, some of it may be more elaborate. But I think one of the interesting, innovative things we're going to try is try to embed a behavioral design team to help clinics in that approach. And if that works for the health agency, we certainly are planning to reach out to federally qualified health centers to work with them in that approach. I think this is kind of innovative in the sense of the government sector. I know Kaiser Permanente has probably been doing this for quite some time, but so we're actually borrowing from you guys. And if you guys want to visit our new media public education webpage, we just recently updated this. I'm going to jump ahead a little bit here. So, from a public health standpoint, and this goes back again to what we're thinking of for cardiovascular disease as well, we recognize that clinical care continues to be very important. Individual interventions that actually affect health behaviors continue to be important. But we also know that we have to work on the environment, physical environment, trying to increase more opportunities for physical activity, better food environment, those really matter. And then recently, we recognize that we also probably need to work on some of these social conditions that do actually impact the way chronic disease develops, and also the way we actually manage chronic disease. So, in a snapshot, what are we doing and what could we do from a very high level, upstream level? Obviously, if we want to deal with obesity and chronic disease, we certainly could work on clean air, free water. Transportation actually turns out to be a very important common element that everybody talks about. Healthy foods. And as I mentioned, opportunities for physical activity. Recently, we've been starting to think also about maybe we need to deal with neighborhood safety and crime and violence. It seems kind of far away, but they do impact chronic disease as well. And then, of course, mental health and substance addiction. So, in terms of the food environment, the last probably decade or so, we've actually been working with hospitals to try to improve the type of food and beverages they offer. It's always you like that? It's always surprising to me that they could have low sodium and really good food for patients, and then you walk downstairs in a cafeteria, they sell probably all the stuff that they would not give the patients. And so we've actually have started this Healthy Hospital Food Initiative, and modestly successful. I think we have much more to go, but there's certainly a number of medical centers that has signed on. And we've been able to do things like help them adhere to better nutrition standards for their cafeteria. We've actually have hired a consultant to provide technical assistance to help them with things like what they call behavioral economics, just placement of food which is actually a fairly effective way to go about it. We're doing sort of the same type of thing in the community. We've worked with LA Food Policy Council. One of the things we're trying to do is increase more fresh vegetables and fruits and vegetables and fresh produce in the community. And one of the way we've been doing it is we actually help the Food Policy Council start a small store purchasing cooperative, which basically means you have these, it's up to 49 stores. Actually, it's more than 49 now. But the idea is that these smaller stores, which generally do not have the buying power to negotiate better contracts for fresher food, actually can bind together and actually get better affordable pricing. And by doing that, these stores can actually, especially in low-income communities, actually then afford to provide more fresh fruits and vegetables. It's actually, the Center for Disease Control is actually quite interested in this approach. And so far, we've been doing this for about 4 years, and it's been growing. It's actually working very well. The other type of intervention that's very popular is, of course, farmers market, and we've been doing that as well. Share use agreement. The other thing we've been trying to do in terms of cardiovascular health and just generally increasing opportunities for physical activity. We work with a lot of schools and school districts to try to negotiate what we call share use agreement. It's just an agreement. We usually bring together community organizations that's willing to provide services or programming, and we kind of link them up with a school, and then they sign an official contract to actually open up the facilities to actually allow community members, not just students, but actually community members within a radius, so they could actually come in and usually
Can we all just stop for a moment
Sure.
and recognize how innovative that is? I mean, that is just so important.
Yeah,
And thank you for doing that.
No, we think this is wonderful, especially in low-income areas where, frankly, you don't have enough open space and you don't have enough parks. This is a really easy solution. Although easy in the sense that you could really open up the facilities. Negotiating the agreement, that's not so easy because they get into the details of who actually has the liability, who actually cleans the bathrooms and
who does that?
Usually it's the school, but sometimes the community organizations would kind of offer resources. The agreements, what we found with different type of agreements is that they are very different from one community to the other. The one common theme we did find is that if you're going to do a share use agreement and you're going to open up open space and facilities, you should offer programming. Otherwise, people won't come. This is that was one of the studies that we did, and that's what we found, that you got to offer programming, or it's a case of you build it or you open it but nobody actually shows up. Moving one step even more upstream, we certainly work with Department of Planning, transportation departments to really sort of work on streetscapes and community plans. I don't know how many of you guys ever talk to community planners. They get very excited about maps and more maps, and they talk about what they can do. And it's really kind of interesting process because in community planning, you could do you could actually impact zoning laws, and what that is that you could kind of, like, for example, I know in tobacco retail, you could kind of say you can't have a tobacco store within a radius of schools, right, of kids. And same thing for walk-in purposes. You could actually put in the community plans or general plans of cities, health elements that actually list out some of these zoning opportunities. And that's another way in which you could not only create walking opportunities, but also ways to create safe environment. One of the initiatives we have been working with the board and the city of LA is Vision Zero, which is we're using data to try to find where are the intersections that has high collision rates. And then we're working with the Transportation Department to actually do a streetscape modification so that it becomes safer. And there are things you could do. You could put in curbs that actually slows down traffic. You could even change the timing on the crosswalk. As you know, for me, timing on a crosswalk, especially in terms of safety for older adults and disability individual, for example, is kind of critical. I don't know about you, but I can't seem to get through a crosswalk without it going red. And I think I'm relatively healthy.
Quick question on the zoning rules.
Yeah.
Could they be used to do something like displacing the alcohol and snack stores with real food?
Yes, the zoning can be used in that approach. Sometimes the difficulty, what's hard in LA County is we have 88 cities, and so sometimes just the diversity of the residential area in the cities, but it can be done, and what we often do, speaking of policy development, is we often start with unincorporated area, which is within the control of the county. And then if we do it well, we actually offer it as like a model to the other cities to consider. And sometimes it's vice versa, because like City of LA frequently is very progressive, and they will actually start out with an intervention that we then actually borrow for the county. And then media, we are known for public education. I don't know, how many of you actually have seen some of these? Probably most likely, I think our most popular one is the 22 pack of.
Can you read that? I can't see it.
Sure. So we have done a whole series. So one is like Soul Shocker videos, which is mostly, it's on YouTube and social media. And it's like a series of videos that tells you certain food are actually high in sodium that you didn't know about. I think cottage cheese was one of them. This other campaign in October 2011 is our Sugar Pac Campaign. It basically says, it's just a poster. It was actually all over the metro train stations. But the message says, and I'm going to have to look closer to read this. It basically says, you didn't eat 22 packs of sugar. Why are you drinking it? And then in October of 2012, we actually tried to do a portion size control. This one had mixed results because we're trying to demonstrate that you could actually get lower calories, but I think some of these poster people, when we did some intercept survey, actually thought it was better pricing to take it down. And better to do supersizing. So, 1422, in the last 3-4 years, we've actually worked in conjunction with state and also San Diego. This is the Center for Disease Control and Prevention's funding, where they ask us to implement 15 strategies that address everything I just kind of talked about, everything from the physical environment to the food environment. To what's interesting about this grant is for the first time really focus on cardiovascular disease. The two areas they ask us to actually work on are health system strategies to improve blood pressure control, and then the other is to actually scale the National Diabetes Prevention Program within LA County. And the health system strategies, we've actually been asked to try everything from trying to improve meaningful use of the electronic health records in terms of data, to trying to find a better way of identifying and treating undiagnosed hypertension, and also to kind of look at ways in which we can better use community health workers and sort of pharmacist-led comprehensive medication and therapy management. And Hattie, that's how I ended up working with Steve Chen so much, and it's part of this effort. And I'm sure the state has parallel efforts going on.
Could you just say a little bit about the cardiac rehab bullet that was right after that?
Oh, yes, that we have not started yet, but it's one of the things we are starting to think about. As you know, a lot of people who have a heart attack afterwards, oftentimes it gets lost to actually appropriate care and rehab, and they tend to do worse. And I think that leads into the RightCare initiatives work with heart failure. You want to prevent that. And so one other thing we've been thinking is that we could, and CDC is thinking along the same way, there must be a better way to identify and help people who just came out of hospital with heart attacks to actually adhere and stay within cardiac rehab programs. And part of that is a system change. I also think part of the other thing that we will have to try to address is the issue around depression and mental health, because I think there are other factors that actually play into why people are not actually accessing or staying in some of these programs that you would otherwise think would be very beneficial. So in terms of public health's approach in the health system arena, we certainly try to provide technical assistance, as I mentioned. We try to engage leadership, not so much to educate them as much as to kind of point out ways in which maybe a more population health and system level perspective might help them tackle some of these issues. Where we could, we provide funding. That last one is actually very popular among organizations. And then recently we've been moving towards trying to strengthen community clinical linkages. And what we mean by that is there are a lot of resources. I mentioned you have opportunities for physical activity, you have the National Diabetes Prevention Programs, you have a lot of these other programming that are actually usually out in the field. But oftentimes, the primary care doctor, they see the patient, all they could do is they diagnose, and they might even offer advice and counseling on what you should do, but oftentimes there's no clear linkage on then who do you consult, and what resources do you go to try to find these opportunities. And so we try to do that. We're working towards trying to make it easier for patients and for even providers to do that. So just to give you an example, since we started about 4 years ago on a national diabetes prevention program, we've certainly have increased the capacity. I think one of the, early on, what we recognized were these sort of three things. One, supply. Even though it's an evidence-based program and it seems like a good thing to do, the fact of the matter is, when we started in 2014, there were only 12 organizations, 26 locations that's actually providing this type of services. By 2017, we've been able to increase to 107 sites. We're continuing to foster growth. The other thing that we realized that we needed was be able to share best practices and actually disseminate sort of on-the-ground knowledge, and so we actually formed a coalition on diabetes prevention. Actually, it's not unlike RightCare initiative. We probably kind of borrowed some of your elements to try to make that work.
That's great, thank you.
And then the third thing that we realized, which we kind of hit very hard on, was trying to get coverage. Because we realized that even if we increase the supply and even if we have grant funding to kind of support it for now, eventually what we need is some type of sustainable solution. And I'm happy to report that in California anyway, beginning next year, 2019, I believe the state and Medicare is going to pay for it. It's going to reimburse for National Diabetes Prevention Program, and simultaneously CMS is going to do so for Medicare. And again, to give you an example, we've certainly invested also in resources. We've to help with the coverage. We actually worked with Change Lab Solutions to actually come up with sort of a toolkit on how to do coverage through managed care and Medicaid. We invested in this at this corner down there, One Degree website, which actually allows providers anywhere. This is actually free of charge.